So question number 152. You are dispatched to a residence for a 67-year-old female that was awakened by shortness of breath and sharp chest pain. Her husband tells you that she was recently discharged from the hospital after having hip surgery. Your assessment reveals dried blood around her mouth, facial cyanosis, and an oxygen saturation of 88%. This patient's presentation is most consistent with what? Going through these answer choices, A says acute pulmonary edema. What is edema? Yeah, specifically it's talking about fluid gathering in some part of the body. So if it's in like an extremity or something, it really looks like swelling, but specifically it's that fluid that's building up in that area, in those tissues. This wouldn't really make sense. It's not indicated anywhere, except it says pulmonary, so yeah, breathing problem. But the edema side of things, I don't see any reason why that would be happening necessarily to this patient. There's just nothing to point to that. Right-sided heart failure. Remember we talked last time about CHF, maybe it was a couple times ago. Your CHF is where your heart, one side or the other, or sometimes all of it, is too weak to be working properly and pushing the blood out properly. If you have right-sided heart failure, what does that mean? Where's the blood backing up to? Into the body, not into the lungs, remember? Because blood goes from the body into the right side, to the lungs, into the left side. So if the right side's not working, that blood is backing up into the body. Remember, that's when we see the JVD that we talked about. That's when you see things like pedal edema, swelling in the extremities, specifically in the feet because of gravity working against you. Is there anything in this question to indicate that she's having right-sided CHF? No. We don't know anything about her history that would point to that, and none of her signs or symptoms seem to point that direction. Acute pulmonary embolism. What is an embolism? Yeah. It's a clot or it's a something. So it's either a blood clot or it's a little piece of fat or air or something that's in the bloodstream. If y'all remember the difference between an embolus and a thrombus? No, you were right the first time. A thrombus is the one that stays wherever it develops somewhere, and that's where it clots up. An embolus is something that has broken off, like it was a thrombus that is broken off and is now moved. You might see this on your test. It links up DVT, which is deep vein thrombosis, to things like pulmonary embolisms or brain embolisms, different things that Mike could talk about. That DVT is essentially some of the veins in your legs. If they're having poor circulation, they might develop thrombosi. Not really sure what that plural is, in those veins, and then when they break off, they can travel up to the parts that really matter, like heart, lungs, brain, things like that. Okay, so a pulmonary embolism. Is there anything in this question to indicate that might somehow connect? Yeah, the surgery is actually a really good clue. So your patient had hip surgery. More likely than not, there was some amount of blood clotting inside the body that happened during that surgery. If a clot has broken off down there and traveled up through, it can have lodged somewhere in those small vessels in the lungs, which would potentially be causing this. If it's blocking one of those vessels, then you're going to have a hard time getting enough oxygen. So you're going to have that cyanosis, low oxygen saturation. That blood around the mouth is another really good sign. Again, there's a blood clot, so something's going on between the blood and the lungs that isn't working properly. And then we look at D, spontaneous pneumothorax. Is there anything in the question to point towards this? No. Specifically not when it's said hip surgery. Like, I know sometimes those things can be red herrings if they have extra information, but in this case, that's actually pointing towards this specific situation that they want you to recognize, which is that embolism in answer choice C. 151 was a duplicate of one of the earlier questions. The answer choice for that was A, if you didn't have it already copied down on your sheet. Number 153. You are dispatched to the county jail for an inmate that is, quote-unquote, sick. When you arrive, you find the patient, a 33-year-old male, unresponsive. His airway is patent and his respirations are rapid and shallow. Your initial action should be what? C is the correct answer. This is pretty straightforward. We've done this kind of question multiple times. You've got your ABCs that need to happen. And in this case, it makes sense that he would need assisted ventilation because his respirations are already rapid and shallow, so that's probably not adequate. A pulse oximeter and blood pressure are both vital signs, or pulse oximeter gives you is O2 saturation, which is a vital sign. And requesting a paramedic unit, there's nothing to indicate that yet. That's farther along down the line than dealing with ABCs. Number 154. Following delivery of a full-term baby, you have properly cared for the baby and have clamped and cut the umbilical cord. During transport, you note that the mother is experiencing moderate vaginal bleeding. What should you do? Now, I don't remember if we have talked about this a ton when we were going through the OB-GYN stuff. The answer to this one is B. Did we talk about a fundal massage in this class? Okay, so this is exactly asking you to do a fundal massage. The fundus is kind of, I guess, the top portion of the uterus, essentially. When you're doing a fundal massage, you've got the uterus in there, which is about the size of a grapefruit or slightly larger at this point. It hasn't fully contracted, especially if the placenta is still in, and we don't know. It hasn't said anything. Massaging it in a circular motion from the outside helps stop bleeding. It can help expel the placenta if that's still inside and hasn't properly birthed yet. It's essentially, it's what we do in this case. That little bit of bleeding that's going on, this is the correct procedure. C is definitely wrong because you don't ever put anything into the vagina, at least not like this, not a dressing. You only ever put your fingers in certain cases, and you don't ever put dressings or things just into it. And the other two are positioning questions, and neither one of them deals with the fact that she's bleeding. So even though A looks like we're dealing with shock treatment, we actually have a very specific way we can deal with this kind of bleeding. And so this is one of those situation questions where they expect you to know what this is and how to deal with it. And that's a fundal massage. In case y'all have forgotten how to spell it, so I can get this. Fundal massage. So, question number 155. Upon delivery of an infant's head, you note that the umbilical cord is wrapped around its neck. What should you do? Anyone remember what this is called? We have a specific term for it that starts with an N. It's called nuchal cord. Let me write this one. Hold on. When an umbilical cord is wrapped around the baby's neck, it's called a nuchal cord. So, that's not what I wanted it to do. It went away. Sorry, guys. Hopefully you caught that real quick. If this is the case, how do you deal with it? Yeah, you put 2 fingers underneath the cord and carefully try to slip it over the baby's head. What if it doesn't move? Yeah, if it doesn't move after one attempt, usually just one attempt is all you'd be able to really do, you'd go ahead and clamp and cut. Why wouldn't we want to clamp and cut right away? Yeah, so remember, when you're dealing with the delivery of an infant, which hopefully you don't have to do because doing it in an ambulance is certainly not preferable to doing it in a hospital situation. But remember, you don't clamp and cut that cord until it has stopped pulsating, until the pulse has stopped traveling through it. Because as long as that's happening, some of the baby's blood or a fair amount of the baby's blood is still in the placenta. You want it to have that going. Let it end naturally. It'll take a couple, 30 seconds, a minute, whatever. Once that has stopped, then you can cut the cord. You don't want to just cut it right away here because you don't have as much space to work with when it's all wrapped up real tight. And also, that pulse is still going, and you want to avoid cutting it before that. However, you don't want to wait a long time. You don't want to keep trying multiple times and have it not work, because every second that this is wrapped around the baby's neck, what is happening to the baby? They're not getting the nutrients in their body. So they're not really breathing. They're not getting oxygen through their own breathing yet. They're still getting the oxygen that has passed through from the mother's blood and the placenta through to the baby. But if it's wrapped around their neck, it's like if you were to crimp a hose. Nothing is getting through that hose to the baby. And so not only is it wrapped around their necktie, which certainly isn't good, but the hose itself is crimped shut and nothing is passing through. Try once. If it doesn't work, you just clamp and cut. So in this case, the answer is D, because that's the most appropriate way you manage this. Number 156. You receive a call to a residence for a sick patient. Upon your arrival, you find the patient, a 53-year-old diabetic male, lying down on his front porch. His wife tells you that he had been mowing the lawn in the heat for the past 3 hours. The patient is confused and has hot, moist skin. His pulse is weak and thready, and his blood pressure is 90/55. In addition to administering 100% oxygen, what should you do? So in this case, it's another one of those situational questions where they're giving you a very specific setup and set of vitals and expecting you to know how to deal with that particular setup. You'll see a lot of those with all the environmental ones. All we've seen with these spider bites, snake bites, things like that, they're all environmentally based, and they want you to know how to deal with that environmental situation. It's not excluded to those, but that typically we see a lot in that kind of case. So yeah, in this case, C is the correct answer. You'd start cooling interventions immediately. You should be suspecting some sort of heat injury based on the fact that he's been outside in the heat for the past 3 hours, confused, so altered mental status, hot, moist skin. His body is still compensating for the fact that he's outside, but his skin is, it's hot and it's moist. It's doing something, but clearly he's hurting with the heat. His pulse is weak and thready. His blood pressure is low. Again, those are classic signs of heat problems. So C is the best choice. D doesn't make any sense. We don't think there's any diabetic thing going on. There's nothing to indicate that. A doesn't make any sense. There's no reason to assume that it's trauma. And again, we don't have such a thing as a rapid medical assessment. We have a rapid trauma assessment, but we've never really used that phrase, rapid medical assessment. And why would B be wrong? Or why would B be worse than C? Yeah, we don't give them stuff to drink. Especially not 1 liter of water all at once. If you've ever dealt with somebody who's having heat problems and hasn't been thoroughly hydrated, you don't give them a whole bunch of water at once. You give it to them in sips, slowly, carefully. But we don't deal with that anyway. So yes, B is wrong because of that. The answer here is C. Number 157. You are dispatched to an apartment complex where a 21-year-old female has apparently overdosed on several narcotic medications. She is semi-conscious and has slow, shallow respirations. What should you do? So in this patient, what should be our primary concern? Just like with any patient, remember ABCs come first. And for this patient, we know something about her airway breathing, which is it adequate? No. Slow, shallow respirations. Almost anytime they use the word shallow, it seems, they want you to think that the breathing isn't adequate. Whether they say rapid and shallow or slow and shallow, that word shallow always seems to signify not enough air is getting through. In those cases, you've almost never chosen the choice where it's a non-rebreather versus ventilations. Side note. So you have this patient who needs respiratory assistance somehow, something having to do with oxygen or airway, breathing somewhere, something like that. Looking at the answer choices. A, insert an OPA and perform oral suctioning. Your patient is semi-conscious. Is an OPA indicated in a semi-conscious patient? No. Also, there's nothing to indicate that she needs suctioning at this point. We don't know anything about secretions. Yes, she may have them, but it's not mentioned, so it's not part of the answer. B, apply oxygen via a non-rebreather and transport at once. No, we've already kind of discussed slow, shallow respirations. We're thinking she needs more than a non-rebreather. She probably needs ventilatory assistance. C, insert an NPA and begin assisted ventilation. Yeah, there's nothing bad in that answer. It's both things, and it could be useful to your patient. D, place her in the recovery position and monitor for vomiting. You're not treating your patient. Recovery position is for people who are unconscious or semi-conscious or something, but that can manage their own airway, and you're just rolling them to make sure they don't vomit or have a whole lot of secretions build up. But people who are breathing normally, and this patient is not breathing adequately, so the recovery position's not treating for her main problem. Because of that, C's got to be the only good answer out of this bunch. Number 158. A 30-year-old male was rescued after being lost in the woods for approximately 18 hours. The outside temperature is 30 degrees Fahrenheit. He is immediately placed in the warmed ambulance where you perform an initial assessment. He is unconscious, pale, and apneic. After initiating artificial ventilations, what should you do? What is something we have to be really careful about when we're dealing with patients who have hypothermia? Not heating them up too quickly. You want to heat them up for sure, but not doing it too rapidly or too vigorously. You wouldn't want to take one of these patients and rub them really, really hard. That extra shaking that might happen from that. All of that stuff is potentially going to cause cardiac problems. Put them into VFib, because the heart's just not meant to tolerate this kind of stuff. Anyway, that's kind of a side note. Based on these choices, one of them pretty clearly happens before all the rest. B. Yeah. You know that he's unconscious, he's pale, he's apneic. What you don't know anything about yet is his pulse. So you need to assess his pulse. Now, maybe this was confusing for y'all. Why would you check his pulse for up to 45 seconds? Because he's cold. Yeah. Typically in a patient, how long would we check? Like 10 seconds, right? In an unconscious patient, you would check for about 10 seconds on the carotid pulse, 5 to 10. For a patient who's in this state, you want to check for a whole lot longer because the outside temperature is 30 degrees. He's been lost for 18 hours. You can expect his core temperature to be lower. Everything slows down. His pulse slows down. You want to take the extra time to make sure whether or not you can feel it. Give yourself that extra time is fine. You wouldn't begin chest compressions until you have a pulse. You would not apply those chemical heat packs. We talked about warming somebody up too rapidly or too vigorously. That's a little bit much. And you wouldn't apply an AED before checking a pulse. Remember, AEDs only see if they're in VFib or VTAC, so it's not going to give you a picture of what his heart's really doing. It would only tell you if it was doing one of those two things. And you can get a better picture just by taking his pulse and seeing if it's beating at all. 159. You receive a call for a domestic dispute. When you arrive at the scene, you find a young male standing on the front porch of his house. You notice that an adjacent window is broken. The patient has a large body build, is clenching his fists, and is yelling obscenities at you. Which of the following findings is least predictive of this patient's potential for violence? So when we talk about least predictive, we're meaning which one of these things doesn't necessarily indicate that he might hurt you, right? So A says his clenched fists. Is that a sign of violence or aggression?
Yeah.
Okay. B, the broken window. Is that a sign, or is that related to violence or aggression?
Yeah.
Yeah, potentially. I mean, it could be that the kid next door threw a baseball through it the day before. It could also be that this guy just broke the window because he was so mad. It's certainly a sign that maybe something is going on. C, shouting obscenities. Is this a sign of violence or aggression?
Well, I mean, it could be, but a lot of times people are just going to cuss at you because they don't like you, that kind of thing.
That's possible. Okay, so it could just be that this guy has a really foul mouth. D, his large body build. Is that a sign of violence or aggression? No. So even though broken window isn't necessarily a sign and shouting obscenities isn't necessarily a sign, nothing about somebody just being a larger person automatically means that they're violent. It sometimes is taken that way. You can kind of be more intimidated by somebody who's just physically larger, but realistically, it's not an actual sign that he's going to be violent at you. Whereas shouting obscenities is kind of implying that he's angry, whether at you or at somebody. That anger and then the clenched fists and already that he's probably broken something, all kind of are tying together to mean be cautious. Whereas you don't have to be automatically cautious of a patient just because they're 6'6" or something. 160. A 35-year-old mildly obese woman is complaining of localized pain in the right upper quadrant with referred pain to the right shoulder. The most likely cause of her pain is what? Okay, of these answer choices, are there any of them that you recognize?
C and D.
Okay, so C, appendicitis. What is appendicitis? Inflammation of the appendix. Remember that itis is inflammation of whatever it was just talking about. Inflammation of the appendix. D is inflammation of the pancreas. Okay? So knowing about, knowing about the location of those two organs will help you kind of understand what's happening. First off, this idea of localized pain and then referred pain, do y'all remember that? We've talked about it specifically in dealing with heart attacks, right? So you might have pain at the actual like chest pain in general, but where do you also see referred pain in a heart attack? Yeah, down the left arm and then the back, sometimes all the way up to the jaw. You see that referred pain, and it has to do with the way the body produces these nerves that fire off. Sometimes the pathways just get literally crossed, and so even though it's coming from one location, it feels like it's coming from somewhere else based on the way the nerves all connect up. This sort of referred pain also is very specific to this type of injury. Basically, there's a couple organs that are in the right upper quadrant that do send signs of referred pain to the right shoulder. So what organs are in the right upper quadrant? Your liver, and what else? Gallbladder. Those are the two that you should remember specifically as right upper quadrant. So, well, I'll get there. First off, are the appendix or the pancreas in the right upper quadrant? No. Remember, appendix is lower right quadrant. Pancreas is kind of next to the stomach, which is up in the upper left. But neither of those are upper right. So you've got acute cystitis and you've got cholecystitis. This would be something for you guys to just be able to remember. But if I were to tell you that one of those is the bladder and one of those is the gallbladder, which one do you think would be the bladder? Try again. The bladder is cystitis, and the gallbladder is cholecystitis. Okay? Cystitis, it would be like a bladder inflammation or bladder infection. So it could be something like a UTI even. Sort of the more commonly known urinary tract infection is a form of cystitis. So now that we know all of our words and we know where we're feeling this pain, we know what organs are there, what's the correct answer? B, cholecystitis. We have that pain that's in the right upper quadrant, which is where the liver and gallbladder are. Cholecystitis refers to pain and inflammation in the gallbladder. Therefore, that's the correct answer. And this is something you should be aware of, this referred pain thing. Like I said, we've talked about it in reference to the heart, but the liver and the gallbladder have that very specific pattern up to the right shoulder as well. And you might see that on the test. Number 161. A 40-year-old female is found unconscious by her sister. The patient has a history of diabetes and has been treated for hypoglycemia in the past. What should you do? Looking at these answer choices, A says place oral glucose between her cheek and gum. Do we give oral glucose? No. Yeah, no, never like that. You don't give it unless they're conscious, and then you give it to them like to drink, essentially. Or it's a gel, but it's more or less drinking. You don't place it in the mouth and hope that it works. It would, to some degree, it would absorb, but that's not how we do that at all. B, give oxygen and oral glucose and transport rapidly. No. Do we know yet that she actually needs glucose? No. Also, we can't give oral glucose when she's unconscious, so that's 2 marks against that. C, give oral glucose and carefully monitor her airway. No, we don't need this. We don't know that she needs oral glucose, and we can't give it to her because she's unconscious. So the only answer choice that is at all possible is D, administer oxygen and transport her at once. Everything else is giving oral glucose, and that's just not correct at all. One of the main contraindications is being unconscious. 162. You are assessing a 45-year-old female who is severely depressed. She states that it seems as though her entire world is crashing down around her. She further states that she has had frequent thoughts of suicide, but is not sure if she can actually go through with it. How should you manage this situation? Looking at these answer choices. A, ask the patient if she has developed a suicidal plan. B, leave the scene and have a neighbor check in on her. C, have law enforcement place her in protective custody. Or D, encourage the patient to remain quiet during transport. Most of y'all were voting either A or C, right? B is definitely wrong. Why? You never leave your patient and have a neighbor check in. Like, that's your job. That's why you were called out there. So that's completely avoiding your job. And D, encourage the patient to remain quiet during transport. It's kind of rude. It's not treating anything. Again, it's sort of a non-answer. It's like, what are you doing? You have a patient who's complaining and feeling like nobody cares about her and her world is crashing down, and you're like, ma'am, I just need you to hush. Like, I just don't want to hear your problems right now. Like, how is that helpful in any stretch of the imagination? So B and D are definitely out. Okay, between A and C. Ask the patient if she has developed a suicide plan. So this would be you asking the patient, basically she says she feels depressed, she's had thoughts of suicide. A suicide plan would be basically if she had made that next step. So it's the difference between saying, I want to kill myself, and saying, I know my husband keeps a gun in the locked bedside drawer, or saying, I know where I can get enough, I don't know, drain cleaner or something to swallow, whatever her plan is. I mean, that would be her plan. That would be her suicide plan. It's going one step farther from just having thoughts, because planning it is a whole different realm of like, she needs help. I don't mean that in a bad way. It's one thing to be depressed. It's an entirely another thing to actually have a plan for doing away with yourself. C, have law enforcement place her in protective custody. You were right, Nicole. Law enforcement does start to get involved when it's a suicide thing, or at least the legal side of things, because suicide is illegal. I mean, from a they're not going to prosecute you, but it is not something you're supposed to do according to the law of the land. So yeah, if you've got a patient who is suicidal, there are social workers and all kinds of public people that can help her. However, look at this choice a little bit more carefully. Have them place her in protective custody. That's a little bit outside the scope of what we do. It's one thing to notify supervisors or staff or law enforcement. It's one thing to notify them. It's an entirely another thing to have her placed in protective custody, which isn't being arrested, but it's like kind of a step in that direction. In other words, this is going too far. The best choice would be A, because asking if she has developed a suicide plan is trying to get a better understanding of what's going on with her. So if you know this patient has a plan, you know maybe a little bit more in depth what kind of help they're needing, what's going through their mind. It helps you understand your patient better, kind of helps you be aware of the hazards that might be involved. If she has a suicide plan and it somehow involves you and the ambulance and the drugs you have on the ambulance, I mean, that'd be good to know. I'm not saying that's what it would be. I'm just saying you do want to know that thing. That would be important. So the answer choice is A. The best answer choice is A, because that protective custody thing is outside of what we would deal with. Number 163. Your unit is dispatched to the county jail for an intoxicated inmate. Upon arrival, you find the patient, a 33-year-old male, lying supine in a jail cell. He is responsive to painful stimuli only and has slow, shallow respirations. You should be most concerned that this patient might what? Should you be concerned that they may become violent? Not really. He is just one step up from unresponsive. So unless he's a really good actor, we're not thinking that he's trying to fake us out. We're not thinking that he's going to be violent. We should be thinking about care for the patient, because there's nothing to indicate that there's still some sort of hazards. B, that he may vomit and aspirate. Possibility, because he is intoxicated. Okay, we don't know what from, drugs, alcohol, something else. But yeah, that's totally a possibility with this sort of situation. C, that he may experience a seizure. Not really. There's nothing to indicate epilepsy. And yes, seizures can happen with people who are intoxicated, but not just in general. It would be more as somebody who's experiencing delirium tremens. Seizures can be associated with that. But there's, again, nothing to indicate that here. He's unconscious. He's not having the hallucinations and things that go alongside delirium tremens. D, is most likely hypoglycemic. Is there any indication that he is diabetic? No. So the best choice here is B, that he might vomit and aspirate. Remember, aspiration is drawing that liquid back into his lungs, like breathing through the vomit or whatever. That's what you want to be really concerned about. 164. A 40-year-old male presents with pain to the right upper quadrant of his abdomen. He is conscious and alert with stable vital signs. During your assessment, you note that his skin and sclera are jaundiced. What should you suspect? We have vocabulary words here. What is sclera? It is the white portion of your eye. Okay? What is jaundice? Yellowed, yes. What organ deals with that? Yes. So the best choice here is definitely B, liver dysfunction. This is straight up a vocabulary question. Even if you don't know what sclera was, jaundice has to do with the liver every time. That's what you should choose. Number 165. You are dispatched to a residence for a 66-year-old male who, according to family members, has suffered a massive stroke. Your initial assessment reveals that the patient is pulseless and apneic. What should you do? Going through these answer choices. A, assess the patient for a facial droop and hemiparesis. Your patient is pulseless and apneic. Is your patient conscious? No. Can you assess him for hemiparesis? Can you say, sir, please hold up both your arms? No. A would be a stroke, like somebody who's still conscious and able to follow directions or do something like that. It's totally not appropriate. B, initiate CPR and attach an AED as soon as possible. Yes, not even just a maybe, but a big yes, right? If you have a pulseless apneic patient, that's what you do every time. CPR, right away. Looking at the other two, blood glucose sample to rule out hypoglycemia. Do we think there's any real indication of a diabetic emergency? No. Would it even matter, really? No. Even if hypoglycemia is somehow involved, your patient is pulseless and apneic, right? Hyperventilate the patient to reduce intracranial pressure. All kinds of no, right? There's nothing in there that actually deals with your problem. Your patient is pulseless and apneic. Also, hyperventilating your patient would be big, fast breaths to reduce intracranial pressure. Again, we're talking about somebody with a stroke. These have to do with a stroke, and really that's not what your patient's problem is. The patient's problem is that they need CPR. Any questions on this? I know the answer choice is basic, but is there any other questions? Okay. Number 166. As you are wheeling your patient through the emergency department doors, you receive another call for a major motor vehicle crash. What should you do? Should you A, place the patient in a high visibility area and then respond to the call? No. What is the legal definition of that? Abandonment. Placing them somewhere where somebody will hopefully notice them and running away is not a good option. B, inform the admissions clerk of the situation and then respond at once. No. Also abandonment, because technically to fulfill your duty, you have to pass them along to somebody who has at least an equivalent level of care or can give an equivalent level of care to you. So just telling the admissions clerk, hey, we don't actually know what happened to your original patient. This guy's really hurt. I got to run. That still doesn't deal with your patient at the time. C, leave a copy of the run form with the nurse and then respond to the call. No. You're getting better. You're not only just telling them that there's a patient, but you're also giving them some information about your patient. However, you're supposed to give a verbal report. You're supposed to stay long enough to make sure that you can answer the questions of the doctor or the nurse, whoever is interacting with you. Leaving a copy of your run form is not going to tell them everything that they want to know. And also, it's not their job to sort through your paperwork to try to figure out how to help this patient. Until you have properly passed off care, you're not done with this patient and you can't leave. So therefore, D is the only good answer. You give a verbal patient report to the nurse or the physician, and after you have done that, then you can respond to this call for the motor vehicle crash. If this was a situation and they had an answer choice that was tell your dispatcher of this situation and whatever, something along those lines, that wouldn't be a bad choice either. But in this case, we're asking about abandonment and what constitutes abandonment. And the only good answer choice here that isn't really abandonment is D. Number 167. You receive a call to a residence where a man found his wife unconscious on the couch. The patient is unresponsive, has a respiratory rate of 8 breaths per minute with reduced tidal volume, and a heart rate of 40 beats per minute and weak. The husband hands you an empty bottle of Vicodin, which was refilled the day before. What should you do? So let's look at them. A, initiate ventilatory assistance. Does she need ventilatory assistance? Yes. 8 breaths per minute is fast or slow? Slow. Yeah, significantly slow. And that reduced tidal volume, what does that mean? It's shallow breaths. So in other words, it's not an adequate amount going in and out each time. It's reduced. It's less. It's not enough. So yeah, ventilatory assistance is definitely on that list. Pretty high on that list because we've got your ABCs, and that's in that range. That's a B. That's breathing. B, contact the poison control center. No, we have had questions where we want to contact the poison control center, and yeah, we may suspect that Vicodin is involved, but compared to fixing her breathing, not a priority. C, perform a rapid head-to-toe exam. Not a priority, definitely not compared to an oxygen-related thing. And then D, apply oxygen via a non-rebreather. Well, we've already said she's breathing slow and shallow, and she needs a BVM. Just non-rebreather on her face is not going to be enough. Number 168. A 47-year-old male presents with severe abdominal pain of 3 hours duration. His abdomen is distended and guarded. Your most important consideration for this patient should be what? So when we look at this question, we need to look a little bit real quick at the vocabulary. When we talk about his abdomen being distended, what should that kind of make you think of? Internal bleeding. Yeah, something. What about it being guarded? What does that mean? When we say that the abdomen is guarded, we're talking about clenching or flexing of the muscles in the abdominal wall, sort of an instinctive reflexive protection that your body does because there's some sort of pain or inflammation in the organs underneath them, and your body wants to protect that. So it's automatically flexing up those muscles, trying to keep there from being any sort of extra pressure or impact put on those organs. So you've got a patient with guarding, so there's pain in there somewhere. We know he's in pain. Also distended, so yeah, likely to be internal bleeding. Based on that, what would we want to be concerned about? Shock. Yes, definitely. None of the others are really bad choices. It's just the most important consideration has to be shock, because this is right up there with the ABCs. One of those points for circulation on your test sheet was checking for shock and treating it if necessary. It's right up there. Transporting him in a supine position is part of how you treat for shock. Not bad, but it's just not like the main focus. Assessing his blood pressure to determine perfusion adequacy. Assessing his blood pressure isn't a bad thing, but it's a vital sign. It's way down.
Don't you not need to assess his blood pressure for perfusion?
Yeah, that's not even how it works. You're right. Blood pressure is dealing with how well his heart and his blood vessels are working. Not perfusion adequacy is really more like with the pulse oximeter, because you're trying to make sure blood flow is getting where it's supposed to, carrying enough oxygen. And determining the exact location and cause of his pain, it doesn't really fit with what you're trying to do. It's not more important than worrying about his circulation issues. You're not probably going to be able to determine the exact cause of the pain because it's not your job to. You don't provide definitive treatment. That's a hospital thing. And the exact location, he's already told you it's abdominal. Again, you don't need to know which organ is messed up. You just need to know that something is going wrong. Because you can't treat it if it's a pancreas that is really having trouble, but you can treat the shock that's happening because of that. So in this case, the answer is B. Number 169. A 66-year-old female complains of diffuse abdominal pain and nausea. She has a history of hypertension and occasional depression. When caring for this patient, you should be most concerned with what? A, the possibility that she may vomit. Yeah, maybe. Abdominal pain, nausea. That's a good call. B, determining the origin of her pain. Yeah, of course. We've already kind of talked about how it's not your job to figure out exactly where it is or what's causing it. She already said it's diffuse. Remember, which means kind of spread out all over. So you're not probably going to be able to tell exactly what's going on. C, the emotional effects caused by the pain. This is where they're trying to distract you in the question and talk about her occasional depression. It's another one of those red herrings trying to lead you astray. It is not your main concern. Same with D. An acute rise in her systolic blood pressure. It's relating back to the fact that we know she has a history of hypertension. It's trying to distract you with that. But in reality, what's happening right now is her pain and nausea, and that's what you should be most concerned with right now. So the answer choice would be A. 170. After delivering your patient to the hospital, you sit down to complete the patient care report. When documenting the patient's last blood pressure reading, you inadvertently write 120/60 instead of 130/70, the patient's actual blood pressure. To correct this mistake, how should you handle it? Remember, the records that you make as an EMT are really, really important. They cover your own butt in terms of showing that you did what you were supposed to do. They document that all the correct procedures were followed, again, to cover you and your partner and I guess the company you work for as a whole. They're a good way of defending yourself in court if it comes to that. And it's just part of the protocols is what you have to do. Because of that, you want to make sure that your reports are very, very clear. You would not want to do C or D. You wouldn't want to cover it over with correction fluid, whiteout, and just write on top, because that looks like you're hiding something. Again, you want transparency in your report, you want honesty in your report. You wouldn't want to leave the error on the form and inform the staff of the patient's actual blood pressure like it says in D. Again, you want transparency and honesty. You want to make sure everyone knows what you actually did and it's clearly documented. B would be wrong. Attempting to erase it, again, is trying to hide what you did. Even if it was erasable, and even though it's not a big deal because you're not trying to hide something, it looks like you are. Initialing it, though, is good, and writing the correct data is good. So the only best choice is A. Draw a single line through the error, initial it, and write the correct data next to it. That shows what your original mistake was. The initialing shows that it was you who corrected that. So again, kind of keeping track of the chain of what's happened, and then you write the correct information next to it. Question number 171. A 26-year-old woman complains of a stabbing pain in the right lower quadrant of her abdomen. She states that her last menstrual period was 7 weeks ago and that she had pelvic inflammatory disease approximately 3 months ago. You should be... Sorry, this thing keeps messing up. You should be most suspicious that this patient is experiencing what? Okay, I'm hearing a lot of different B or D. I think I mostly heard. The correct answer choice is D, an ectopic pregnancy. This is one of those situation-specific questions. Typically, an ectopic pregnancy will show up in the first 6 to 8 weeks of pregnancy. So there's a clue there. If her last period was 7 weeks ago, we're kind of right in that good time zone. Also, pelvic inflammatory disease. Women who've had this are more likely to have other complications, including ectopic pregnancies. You can get pregnant if you've had pelvic inflammatory disease. It is possible, but they're more likely to have problems, I guess is what I should say. They're more likely to have more issues if they do become pregnant. Right lower quadrant, that is where the appendix is, but based on the information that we've got going on right now, appendicitis is unlikely. Intrapelvic infection, have we talked about that? Yeah, that's a little bit, you could probably figure out what the words mean and approximately what we're talking about, but we really haven't discussed anything with that name. Spontaneous abortion, that would be a miscarriage. Probably not, because she's talking about pain, but she's not talking about any bleeding, and also she didn't know she was pregnant. Granted, you can have a miscarriage without ever knowing that you had been pregnant in the first place, but it just doesn't seem to fit as well. Ectopic pregnancy fits the timeline, it fits the conditions. And also, remember, for any woman who's of childbearing age, who's past puberty, and talks about abdominal pain, you should always consider ectopic pregnancy as a high index of suspicion that it might be incredibly likely. Number 172. Upon delivery of the baby's head, you note that its face is encased in the unruptured amniotic sac. What should you do? A, give the mother 100% oxygen and transport at once. Yeah, it's not like a bad thing to do, but it's not maybe fitting this question. B, puncture the sac and suction the baby's mouth and nose. Actually, you are. B is the correct answer choice. If the amniotic sac hasn't already broken, it's okay to break it because you want to get to the baby and suction that out. Once the birthing process is started, they're going to start needing to depend on their own lungs. The mother's body is not really going to continue to provide blood the way it's supposed to, or the way it did during pregnancy. And so you want to get that baby to where they can breathe as quickly as possible.
Isn't it like when you're about to give birth and you're about to, like sack and birth, and you're supposed to like look at yourself or something?
You don't have to break the sac before pregnancy. Typically it does. That's what we talk about, like their water broke. That's what we're talking about. The amniotic sac broke open, and that's the fluid that was in there gushes out. It doesn't always break, and so you don't have to pre-break it ahead of time, but if it still hasn't broken by the time you see the baby's mouth and nose, you do want to break it so that they can get good oxygen. And D, noting the color of the fluid before breaking the sac. Not necessary. What they're trying to talk about here is like this idea of if there's blood or meconium or something in the fluid, and that's an important thing to note if you see it. However, if there is blood or meconium, remember what meconium is? Yes, baby poop. If it's in the fluid, you'll see it when the fluid comes out, when you break the sac. So you don't have to note the color beforehand. You just want to get that open as quickly as possible for the baby. Number 173. Colic pain is caused by what? Have y'all ever heard the phrase colic? Like, y'all know what that is? You maybe have only ever heard it in terms of like babies. Yeah. Some people talk about how if a baby has colic, they're crying all the time. That's pretty much how colic is identified in babies. If they're crying all the time, they're deemed colicky. What it actually refers to is B, distension or contraction of hollow organs. So colic is a really general term. It tends to happen a lot with the digestive tract in general. If you're having a lot of gas and pain in the abdominal area, that is colic. It's one type of colic. There's others, but it's a general term for this distension or contraction dealing with hollow organs specifically. Number 174. A 39-year-old male sustained a stab wound to the groin during an altercation at a bar. As you approach the patient, you note that he is conscious, screaming in pain, and is attempting to control the bleeding, which is bright red and spurting from his groin area. What should you do? And in this question, the answer is pretty straightforward. Apply direct pressure to his wound, like you would do with any wound, especially what kind of bleed is this? Arterial, that bright red spurting blood from his groin area, so you're assuming that his femoral artery is severed, and he needs direct pressure right away. That's basic. Number 175. The vagina and the neck of the uterus comprise the what? A, the womb, B, the cervix, C, the fundus, or D, the birth canal. We're going to talk about the fundus, how it is relating to the uterus. Sorry? The birth canal is the correct answer, yes. The womb is sort of a general term for the uterus. The cervix is the specific opening to the uterus from the vagina. We're going to talk about the fundus, and so the birth canal is essentially all the areas that the babies pass through on their way out. Number 176. You have completed your initial assessment and treatment of a 33-year-old male with abdominal pain. As you are performing a focused history and physical exam, what should your partner do? So in this case, you have to think back to your patient assessment. What should be happening around the same time that you're getting a history and a physical exam? And the answer is D, baseline vital signs. Your partner doesn't need to repeat the initial assessment yet because you're really not quite done with this first go-through. Don't need to gather the patient's medications because remember, you're the one that's doing that history. So they don't need to be physically gathering up bottles. And preparing the ambulance stretcher really kind of depends a lot on what you have and haven't done. D is what makes most sense in terms of how we assess patients. Number 177. While eating dinner, your partner suddenly grabs his throat and has a panicked look on his face. He has a weak cough, faint inspiratory stridor, and cyanosis around the lips. What should you do? First off, you remember what stridor is? Sort of a crowing noise that happens when you're breathing, and it has to do with an obstruction in the upper airway. Based on that, and based on what you hear from this question, what's probably happened to your partner? He's choking on something, right? So when we're dealing with a patient who's choking, what do we do? Yeah, you typically do abdominal thrusts, right? Here your patient is coughing weakly. Is that enough to mean that you shouldn't touch him? No. I think we had a question like this a couple days ago, If your patient is coughing forcefully, then it's okay to stop and let them cough. Let their body try to work through it. If your patient isn't able to forcefully cough it out, your patient's body is no longer able to fix the problem, that's when you'd go ahead and step in and do those abdominal thrusts. You don't need to wait until they're completely not breathing at all, if it's clear that their body isn't able to clear the obstruction. Number 178. A 38-year-old male with a history of schizophrenia is reported by neighbors to be screaming and throwing things in his house. You are familiar with the patient and have cared for him in the past for unrelated problems. Law enforcement officers escort you into the residence when you arrive. The patient tells you that he sees aliens and is attempting to ward them off by screaming and throwing things at them. He has several large lacerations to his forearms that are actively bleeding. The most appropriate way to manage this situation is what? Should you A, try to gain the patient's trust by telling him that you see the aliens also? No, we don't lie to patients. Definitely that's not going to help his delusions if you're basically encouraging them. It's not going to help calm the situation down. B, request that the police officers arrest him and take him to the hospital. It's too much. Again, we don't arrest people just because, it's one thing to restrain somebody. It's an entirely another thing to arrest them. They can't just arrest them because you want them to. C, restrain the patient with appropriate force in order to treat his injuries. Possibility, there's nothing really wrong with that one. D, approach the patient and calm him by placing your hand on his shoulder. Not necessarily very safe. It doesn't put anything in there about being cautious for your own safety, and I wouldn't personally want to touch a patient until I was sure he wasn't going to hurt me. I wouldn't want to get up close and put my hand on his shoulder until I knew how that touch was going to affect him. And if I'm getting that close, he can lash out and hit me and hurt me really easily. He's already got freely bleeding cuts all on his forearms. I don't know what he cut himself with, but I don't want him to cut me with that same thing. So appropriate restraint, appropriate force is perfectly justified in this case. Number 179. A 40-year-old male crashed his motorcycle into a tree. He is semi-conscious, has snoring respirations, and has a laceration to the forearm with minimal bleeding. What should you do? Should you A, apply a cervical collar and suction his airway? Is suctioning indicated by the question? No. So part of it's correct, the C collar, but part of it isn't. B, open his airway with the jaw thrust maneuver. Yes, that's the appropriate way to open up the airway of a trauma patient. C, apply a pressure dressing to the patient's arm. Comparatively, that's nowhere near the first thing. It's a minimally bleeding forearm injury. Yes, you will want to treat it eventually, but not first. And these kind of questions are always talking about the first thing. D, tilt the patient's head back and lift up on his chin. That is not the way that you open up the airway of a trauma patient. Yeah, so the only really good answer choice here is B. Number 180. A 48-year-old male is found unconscious in the garden by his wife. When you arrive at the scene and assess the man, you find that he is unresponsive, has labored and shallow breathing, and has hives over his entire trunk. What should you do? You'll know when it's talking about over his entire trunk, you know what part of the body that's referring to? Kind of generally his torso, chest, abdominal kind of area. Yeah. So, should you A, perform a rapid head-to-toe assessment? Not maybe first, right? B, maintain his airway and assist his ventilations. Are assisted ventilations indicated? Yes, because he has labored, shallow breathing. C, ask the wife if her husband has any known allergies. Yeah, it's a good thing, but not maybe a priority, comparatively. And D, apply the AED in the event that cardiac arrest occurs. We don't know anything about his pulse. That's jumping way too far ahead. The best thing here would be to maintain his airway and assist his ventilations first while you're still working on the rest of things, but that happens first.